In this episode of the Nurse Practitioner Podcast, Dr. Alicia Bischoff and Elizabeth Silvers will be providing an overview of eating disorders and the importance of early detection and management by the nurse practitioner. Dr. Bischoff is a primary care pediatric nurse practitioner, and Elizabeth Silvers is a pediatric nurse practitioner and pediatric mental health specialist. Welcome.
Thank you so much for having us. Alicia and I are so thrilled to talk about this incredibly important topic that affects the entire lifespan.
How common are eating disorders and who is impacted?
Eating disorders are very common. In fact, over 5 million Americans have eating disorders, and 90% of those are children and adolescents. Sadly, symptoms go undetected in 50% of clients with anorexia nervosa, 90% of those with binge eating disorders, and greater than 90% of those with bulimia. Eating disorders don't discriminate. Contrary to stereotypes, eating disorders do not affect just the white affluent women, whereas it is true that 90% of those with eating disorders are females. The incidence in males is actually on the rise. We see a higher incidence in boys of color versus white boys, and we also see a higher incidence in the LGBTQ community compared to cisgender individuals. The average age of onset for eating disorders is 12 years of age, but children as young as 6 years old have been diagnosed. Eating disorders often coexist with other mental health conditions such as anxiety, depression, and substance use. Now, COVID-19 has certainly played a role in all dimensions of our lives for the past 2.5 years, and it has magnified the global eating disorder crisis as well. We are constantly looking at ourselves on video meetings, hearing about the COVID-19 weight gain, social isolation, anxiety. There's been a change in our sleep routines. We have fears about food availability and decrease of access to healthcare, as well as suspension of all sports and activities. And these are all possible reasons why there has been an increase in eating disorders. The number of hospital admissions for eating disorders doubled during the pandemic, and those admitted have exhibited higher rates of nutritional restriction and functional impairment. And they're more likely to be medically unstable, thus leading to an increased length of stay. Eating disorders are costly. The total economic cost in the United States in fiscal year 2018 to 2019 was $64.7 billion, which is equivalent to about $11,808 per affected person. Eating disorders are lethal. People with anorexia nervosa have a 10 times greater risk of dying compared to their peers, and the suicide rate is 23 times that of the general population. In fact, anorexia has the highest mortality rate of any mental health disorder due to both starvation and suicide. But the most important thing to remember is that eating disorders are treatable. So our goal of this podcast is to help you recognize those people affected with eating disorders and assist them in the proper treatment regime so that we can get them on the road to recovery.
Thanks for sharing those eye-opening statistics. How are eating disorders classified?
Well, eating disorders are actually classified based on the DSM-5 criteria that was published in 2013. There are 7 different classifications. The first is anorexia nervosa, which is a restriction of energy intake relative to the needed requirements, so thus leading to a significantly low body weight. There's also an intense fear of gaining weight, and there's a disturbance of body weight or image. Now, amenorrhea is no longer a requirement for anorexia nervosa, and this opens up the diagnosis to males as well as females. It is further broken down into 2 subtypes. The anorexia nervosa restrictive, which is when there's a weight loss is accomplished through dieting, fasting, and excessive exercise. And then there's anorexia nervosa binge purge, which is where weight loss is accomplished through binging and purging. The second classification would be bulimia nervosa. This is where there's a recurrent episode of binge eating, which is characterized by eating large amounts of food within a 2-hour period, and there's a lack of control over eating. And this is followed by some type of compensatory behavior to prevent weight gain, such as purging or intense exercise. Now, for males, we more likely see exercise, whereas with females, we see more purging. This occurs at least once a week for 3 months. There is a disturbance of body weight or shape. It is not associated with long-term weight suppression, so that's what differs it from the anorexia nervosa and is more common in Hispanic females. A third classification is binge eating disorder, which did not actually become a formal diagnosis until 2013 in the DSM-5. It's similar to bulimia. However, there's no compensatory behavior to avoid weight gain. In fact, these patients often have significant weight gain. It's actually the most common eating disorder in the United States. It's more common in minorities. And with this disorder, it's actually more equal between the males and females. Now, the next three categories shift gears a little bit. They are all seen mostly in young children and even infants. In fact, prior to the DSM-5, ARFID, pica, and rumination were all considered as feeding and eating disorders of infancy or early childhood. These disorders are not associated with distorted body image or weight loss attempts, and they are often seen in children with developmental or congenital disorders. So ARFID, or avoidant restrictive food intake disorder, now that is our extremely picky eater. So these are often young children, and food consumption is based on appearance, smell, taste, textures of foods, or some kind of a past experience that the child may have had with the food or with eating that particular food. There is not a distorted body image nor a fear to gain weight, but rather food intake is related to likes or dislikes and experiences with foods. Then we have pica, which is a compulsive eating disorder in which people eat non-food items such as dirt, clay, peeling paint. This is usually seen in young children or in pregnant women as well. It can be associated with anemia, so be sure to check iron levels. With rumination, we also see this in young children or an infant, and they actually bring up partially digested food, and they may either keep chewing it, they may spit it out, or they may re-swallow it. So now what happens if the definitions are not met, but the individual is still exhibiting behaviors consistent with an eating disorder? Well, that brings us to our last classification, which is OSFED, or other specified feeding or eating disorder. This includes night eating syndrome, which is a combined eating disorder and sleeping disorder, where the client wakes multiple times at night to eat. We have bulimia without large binges. So this is someone who routinely purges or exercises excessively after eating a regular meal, but they're not actually binging before that. We have atypical anorexia nervosa, and here is where we see a significant or rapid weight loss, but the weight does not fall into the underweight category, which was part of the definition for anorexia nervosa. These clients are often missed because typically a person who has been considered to be overweight or obese is praised for weight loss, when in fact they could be engaging in disordered behaviors as a mean to an end. These clients have the same or even more severe medical complications in comparison to other eating disorders when missed. Now, in addition to the DSM-5 classification, there's also some non-DSM diagnoses. One of them is orthorexia. This was left out of the DSM-5 because there was not enough research at the time when it was published, but it most likely will be included if we ever have a DSM-6, or I should say when we have a DSM-6. It's often seen in athletes, and it mostly revolves around food quality, not the quantity. So this is like wanting to eat the right foods all the time. It's rarely focused on losing weight, but rather eating healthy. Then we have diabulimia. This is for those with type 1 diabetes, where they actually withhold insulin as a way to lose weight. And then drunkorexia, which is popular with college students. And with drunkorexia, we see a decrease in food consumption in order to get drunk faster. We also see comorbid psychiatric conditions, including gender dysphoria, obsessive compulsive disorder, and post-traumatic stress disorder.
Thanks for distinguishing the categories of eating disorders. What is the role of the nurse practitioner in the detection and diagnosis of eating disorders?
So truly every nurse practitioner should be aware of the signs and symptoms of eating disorders because they include every body system, and they also overlap with chronic conditions in many different specialty areas of care. In addition, you can come across eating disorders at every level of care, whether it's inpatient, outpatient, etc. That being said, it is especially important for the primary care providers to be aware of the subtle signs and symptoms because they are often the first to come across these cases at inception. There are many different tools that you can use in the primary care setting, or really in any setting, but we're going to specify the primary care tools right now. So looking at growth chart trends, vital sign abnormalities, and then also evaluating energy intake and substance use. So speaking about growth charts, they can be a key piece of information when determining if a client is engaging in an eating disorder. You should look for significant downtrends or oscillations in weight, or in children, a plateauing of height along their growth curve. Also remember that, as Alicia mentioned, people who are considered, quote, overweight or obese are praised for losing weight typically, and therefore at follow-up visits, if you're seeing a downtrend in weight, it may not initially be recognized as problematic, but if this person is losing weight rapidly, it's especially important to ask questions about their dietary approach and physical activity to ensure they're being managed appropriately and not engaged in disordered behaviors. For vital sign abnormalities, look at their blood pressure and heart rate, and also ask about menses to determine if there are irregularities. It's also helpful to ask about the use of substances which can curb appetite or lead to weight loss. This can include diet pills or teas, laxatives, and inappropriate caffeine use. So other tools that you can use are some questionnaires that really get at the psychological symptoms of eating disorders. These include the SCOFF, SCOFF, Eating Attitudes Test, or EAT-26, the Eating Attitudes Test for Children, or the CHEAT, the Eating Disorder Examination, and there's also a children's version of that as well. And of those, the most well-studied is the SCOFF, and each letter in the title indicates one of the beginnings of a question. So the following questions are for the SCOFF. For example, do you make yourself sick because you feel uncomfortably full? Do you worry that you have lost control over how much you eat? Have you recently lost more than 1 stone or 14 pounds in a 3-month period? Do you believe yourself to be fat when others say you are thin? Would you say that food dominates your life? So a yes to 2 of these questions warrants further evaluation. A real key piece of this information gathering is psychosocial information. And what I mean by this is asking about body image, eating patterns, asking if within the family there are specific food rules. For example, not allowing certain types of foods to be in the house. The classic one is referring to food as junk food that they can't have, or if the person has their own food rules that they have. Relationship with movement is important to evaluate as well. For example, are they skipping meals? And also ask for a 24-hour diet recall to determine if their meals typically include all the necessary components. This includes a protein, a fruit or vegetable, a carbohydrate or grain, dairy, and a fat. I personally recommend referring to the plate-by-plate approach. This focuses on visualizing the plate and what looks appropriate rather than counting calories or measuring food. For athletes, ask about how they refuel after engaging in physical activity because, as you know, their energy intake needs are actually going to be higher than the average person. But sometimes athletes who are engaged in disordered eating will purposefully skip meals or eat less in proportion to their physical activity. An excessive concern with weight, inappropriate dieting, or weight loss require further evaluation. This leads to the physical exam. So eating disorders affect every body system. Think about, for example, how rapid weight loss is reflected in the physical exam. They're going to be fatigued. They're going to have activity intolerance, dizziness, syncope, palpitations, acrocyanosis, cold intolerance, menstrual irregularities, bloating. There might be nausea, vomiting, diarrhea, constipation. You may see with someone who's very underweight lanugo or hair growth on the face or hair loss. And these are just some examples for what you might see in a physical exam. Also, special note about purging. If someone is purging, you should look specifically for calluses on the back of the knuckles. Usually they prefer one hand over the other, so it might not be on both hands. You may see dental decay or swollen parotid glands, which are also referred to as chipmunk cheeks. When considering a differential list, The differential diagnoses list of weight loss often include various medical diagnoses. This highlights again the need for nurse practitioners in any setting to be familiar with the signs and symptoms of eating disorders. For example, you could think about inflammatory causes or irritable bowel disorder. For example, with IBD, you're going to see, like diarrhea, weight loss, bloating, constipation, diarrhea. Those are symptoms of IBD and also symptoms of eating disorders. Also endocrine abnormalities. So make sure that you're also including eating disorders on this list of differentials. So when you suspect eating disorders, you should do a panel of baseline labs. This includes a CBC, a CMP, LFTs, a thyroid panel, which includes a total T3, an LH, an FSH, estradiol or testosterone levels, and a pregnancy test, because if you think about it, somebody who's amenorrheic for several months could be, that could be due to hypothalamic suppression, or they could be pregnant. Also consider a UA, and make sure that you're also within that looking at their pH levels, because somebody who's purging is going to have more alkaline urine, and somebody who has really concentrated urine also could be specifically trying to manipulate their weight. Also consider an EKG for anybody who may have an eating disorder, and also a DEXA scan, which is a dual X-ray absorptiometry scan when they're amenorrheic for more than 6 months or have a history of stress fractures from minimal trauma, because this chronic weight loss can affect bone mineral density. The takeaway point here is that you really don't want to miss these cases, because not only are they preventable, but when they've gone undetected, they can also have deadly complications.
Thanks for sharing those recommendations. What complications do we see with eating disorders?
Well, medical and psychiatric complications can involve every organ system. Cardiovascular, we can see EKG abnormalities, orthostatic hypotension, and poor circulation. For gastrointestinal, we have slowed gastric mobility, which can lead to constipation and bloating. Urinary can lead to kidney failure. Endocrine, we have amenorrhea and bone mineral loss, which is often irreversible. Hematologic, we have anemia. Neurological, we can see seizures or memory loss. Musculoskeletal, we can see muscle wasting, especially with the heart. And we can see stress fractures. For the skin, we can have hair loss, growth of lanugo hair, and yellowing of the skin. Now, for those that are purging, that can lead to its own additional complications, such as tooth decay, ruptured esophagus, tears in the lining of the stomach, and electrolyte imbalance, which can lead to sudden cardiac death. Psychiatric complications resulting from malnutrition include a rise in anxiety disorders, depression, non-suicidal self-injury such as cutting, and sometimes even suicide.
How are eating disorders treated?
So as I mentioned before, the primary care provider is often the first person who's going to come across the symptoms of an eating disorder. They also become an integral member of an interdisciplinary treatment team. This ideally also includes an eating disorder-focused therapist, an eating disorder-focused dietitian, and a psychiatric provider if indicated. So in this case, I mentioned all of these different members of the treatment team because eating disorders affect every area of care. And so it really does require this huge treatment team effort in order to treat eating disorders. In terms of treatment modalities, the most common and also most effective in children and adolescents is called family-based therapy, or FBT. This treatment approach places focus on weight restoration and refeeding first to promote recovery, and it places emphasis on family involvement in recovery. As I mentioned again, it has been shown to be effective for adolescents, in particular with anorexia and bulimia. Also, psychotherapy approaches, including cognitive behavioral therapy, or CBT, dialectical behavioral therapy, or DBT, or ACT, acceptance and commitment therapy, again, used with an eating disorder-focused therapist, should be utilized in tandem with the medical and dietary treatment. Also to mention, when psychiatric comorbidities are present, because they often are, psychopharmacologic treatment is indicated, and it should be managed by a psychiatry-informed provider, whether this is somebody who in primary care has extensive extra training in psychiatry, a psychiatric nurse practitioner, or a psychiatrist. So just to give some examples of treatments, there is an FDA approval use of lisdexamfetamine in the treatment of binge eating disorder. In addition, OCD is a common comorbidity of anorexia nervosa, and so treatment of OCD, for example, with an SSRI medication, could help treatment of the eating disorder as well. There have also been studies that show the use of olanzapine is helpful in treating the cognitive symptoms of anorexia nervosa. It's also important to note, though, specifically that bupropion, which is a common antidepressant, it's actually contraindicated in treating depression in clients with anorexia or bulimia because there's a higher risk for seizures. Medically speaking, the initial labs I mentioned earlier should be ordered by the primary care provider, and then they should be seeing the client for follow-up every 1 to 2 weeks to track the vital signs, hydration status, urine pH, and progress within treatment. Depending on how stable the client is medically, the labs are then repeated every 2 to 6 weeks. And again, as I mentioned before, this should also be this decision-making is done in tandem with the treatment team. Also wanted to mention the use of a blind weight. It's the most common in assessment and management of eating disorders because it helps to support treatment engagement. In eating disorders, the fear of weight gain can lead to high anxiety levels in these clients, and therefore they can avoid these appointments and have a lot of trouble when they're exposed to their weight. So it's really helpful to use blind weights. So depending on the severity of the eating disorder, recovery may require varying levels of care. There is a tiered system where the base level is outpatient, where the eating disorder is the least severe. And if they are failing to reach their treatment goals at the outpatient level of care with the team that I mentioned, they may be escalated to the next level, which is IOP, or intensive outpatient. This is a day program or half-day program several days a week. The next level beyond that would be a PHP, or partial hospitalization program. This is a day program 5 days a week and includes all of the different members of the treatment team that I mentioned. And then in addition, also we'll have group therapy approaches as well, and more frequent appointments with the therapist and the dietitian. Beyond that would be an RTC, or residential treatment center. This is a 24/7 facility that the client will go to, where they are constantly managed medically, psychiatrically, and psychologically. There's also more programming in these at this level of care, and oftentimes this will involve several weeks of treatment before then stepping down to the PHP or IOP level of care. Beyond that, there's the inpatient level of care if the client is unstable medically or psychiatrically. Speaking of the inpatient level of care, the indications for hospitalization medically are if the client is hypotensive with a blood pressure that's less than 90/45, there's orthostasis present of a pulse increase of 35 beats per minute from lying to standing or more, systolic or diastolic change of more than 10 millimeters of mercury for blood pressure with orthostasis as well. If they are bradycardic with a pulse that's less than 50 beats per minute during the day or less than 45 at night. If there are severe EKG abnormalities. If there are severe electrolyte abnormalities, such as with potassium, sodium, and phosphorus. If they are hypothermic. If their weight is less than 75% of ideal body weight. Or if there are other acute medical events, such as syncope, GI bleeding, or severe dehydration. Another potential indication for hospitalization would be acute food refusal, whether this is severe and or prolonged. Like if somebody, for example, suddenly is not taking in any food for 24 hours or more, or with prolonged, they could be actively restricting and not following their meal plan that's set by the eating disorder dietitian to the extent that they are losing weight and becoming medically unstable. Psychiatrically speaking, if there is active suicidal ideation, then this client should be hospitalized. So these criteria are from the Stanford University, but they're widely accepted by the medical community. And it's really important to note that, as Alicia mentioned in the beginning, the hospitalizations have skyrocketed during the time of the COVID-19 pandemic. And so oftentimes The client is not going to actually be hospitalized for any one of these criteria, so you really have to consider the entire clinical picture when considering hospitalization. And so that leads into my next note, which is that the appropriate level of care is really best determined by eating disorder specialists. You really want to get to know who the eating disorder specialists are in your community so that you can consult them with these cases. It's important to routinely assess medical and psychiatric stability in consultation with the eating disorder treatment team to determine a client's ability to participate in treatment at any level of care. I also wanted to use this opportunity to plug the Health at Every Size approach, or HAES approach, in healthcare and treatment of eating disorders. It's really recommended, especially for eating disorders, because it promotes the development of healthy body image in children and adolescents, and also in any individual. It shifts the focus from weight loss to weight neutrality and reduces stigma around weight. The HAES principles include weight inclusivity, health enhancement, eating for well-being, respectful care, and life-enhancing movement. This is a developing area of work, and you can learn more about it on the HAES website, which we can leave in the show notes.
Thanks so much for sharing those insights. Finally, what does recovery look like?
It's important to note that recovery does occur in stages. Oftentimes, it is the numbers that improve first, so we are looking for ongoing medical stability. This happens in the form of weight restoration and or stabilization, depending on the eating disorder diagnosis. So the absence of physical symptoms is usually noticeable shortly after weight restoration, although, for example, reestablishment of normal menses can take 6 months or longer despite being weight restored. So it's not necessarily a sole indicator of lack of recovery if the person has not gotten their period back. The good news is that most complications are reversible. The only potentially irreversible complication of malnutrition is bone mineral density loss, aka osteopenia or osteoporosis. Another great indicator of recovery is the ability for the client to engage in what's called intuitive eating. So their ability to respond to their hunger and satiety cues appropriately. We'll also see a lack of disordered eating behaviors and flexibility in eating patterns. Other indications of psychological stability are improved self-esteem, reduction of anxiety with respect to body image and food, and the abstinence of pursuit of weight loss or conforming to a specific body ideal. It's also important to note that eating disorders can morph over time. So the treatment of an eating disorder doesn't mean a person is not vulnerable to relapse or develop a different eating disorder. So you really want to track these clients over time and ensure that they're not engaging in other kinds of disordered behaviors just because they've recovered from, for example, anorexia. They could then develop orthorexia or binge eating disorder, for example, in the future.
So despite potential for severe complications, earlier intervention and treatment can result in lower potential for relapse and a higher potential for full recovery. In fact, 50% of individuals with anorexia make a full recovery, and another 30% make partial recovery. When we look at bulimia, it has even a better prognosis, with 80% making full recovery. So in closing, I know we've already said it multiple times, but remember, our number one responsibility is not to miss these people.
All right. Thanks so much for your time today, Alicia and Elizabeth. For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. If you like what you heard today, please leave us a 5-star review on iTunes, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at The Nurse Practitioner Journal, and on Twitter at TNPJ_journal. Thanks for listening. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner podcast are not clinicians. However, we created the Nurse Practitioner podcast to bring you relevant clinical information by NPs for NPs. Thanks for listening.